This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Welcome to another episode of the 1 Million Lives podcast. My name is Michael Sauter. I'm the Chief Learning Officer at Laerdal Medical and your humble host in this episode. Today we are so very fortunate to have as our guest Dr. Barry Isenberg. Barry is a medical doctor by profession, an educator by heart, and an intellectual in all aspects of healthcare education. He is the director of the Michael S. Gordon Center for Research in Medical Education in Miami, Florida, and he is also the president-elect of the Society of Simulation in Healthcare. And we are fortunate enough to hear him talk about some of the very special guideposts that has led to his brilliant career, but also to understand more about where healthcare education and simulation needs to move as we head out into this post-pandemic era. With this, I will get right out of the way and leave you with the conversation I had with Dr. Isenberg. Welcome to our podcast, Barry.
Thank you very much, Michael.
If you don't mind, I would like to start this conversation, which I've been looking forward to, with a look in the rearview mirror. I remember when, and I may be younger than you in this game, when I started working at Laerdal back in 2005, I soon heard about the Society of Simulation in Healthcare, but at the same time I also heard about some of these outstanding simulation centers and their rather charismatic leaders. And one of these centers was, of course, the Michael S. Gordon Center for Research in Medical Education at the Miller School of Medicine in Miami, where you are the current director. And I was fortunate enough to meet Dr. Michael Gordon on a few occasions. And like most, I was struck by his charisma and his vision for medical education. I'm curious, how did it happen that you came to work with Dr. Gordon at his center?
Thank you for the opportunity to give a little bit about that history. My story is a little bit unique in that I was introduced to Michael Gordon way back in 1982. I'm dating myself. When I was in middle school, I was 14. And my mother had just joined his center as a development officer, as a director of communications because of her background. And probably after the second day of working with Michael, she came back and she had known I had an interest in medicine. I hadn't really declared that I wanted to be a physician, but also knew I was interested in technology. And she said, Barry, I think I've joined just a wonderful laboratory. You really need to see it. And so it was the next holiday vacation. I had the opportunity of being introduced to the center, seeing what Michael and his team was doing with, at that point, probably a third generation of the Harvey simulator. And it checked all the boxes of everything I had been interested in doing, both in healthcare. I knew I was interested in education and, of course, technology. And then for the next several years during summer vacations and holidays, I would work in various jobs, helping out build the simulator, recording various heart sounds. And it really just cemented what I knew was going to be my passion for the rest of my life.
Wow. So you actually grew up in a way in the center.
I have, exactly. That was many years ago. During medical school, I came back to University of Miami through an unfortunate accident with my lower back. I took actually a full year off of medical school and spent that year really embedded in the simulation laboratory, working with Michael on further developments of simulation. We developed a multimedia curriculum that was pretty advanced at its time. And then I saw how simulation just wasn't a new tool with very persuasive technologies that would capture people. But there was actually a science to education and training. And I was really fascinated about how I could further develop my own skills, but ultimately contribute to that science of learning through the use of simulation.
And forwarding a bit, when Dr. Gordon sadly passed away in 2017, it fell then to you to carry on that work that he started at the Gordon Center. And I wonder, what was it like to suddenly be the captain at the wheel of this renowned center?
It's a great question. And actually, Michael had the vision 5 years before 2017, his untimely passing, to hand over the reins. And so I became the official director of the Gordon Center at that time. It was named for him in 2012. So from 2012 to 2017, Michael served as the emeritus director, and I served in the capacity of director. And it was really a 5 years of being very informative, of having a daily mentor who was bestowing upon me his experience and knowledge, so that I was prepared. We didn't anticipate that it would be a result of his passing. So that when 2017, when that happened, I was more prepared than I would have otherwise been. And it was only because of his foresight and his detailed planning. As you know, he didn't leave anything for chance. And it wasn't until a few years after that I really appreciated his generosity and his humility of stepping down before other people may have, to give me that opportunity.
Just imagine if more people have done it like that.
Yeah.
What a peaceful world we would have, and probably a more productive one as well. So speaking of productive, I'm curious as to, can you say something about the operation at the Gordon Center today? How many people are you and what are you involved in?
So, and also taking a step back about what is the Gordon Center and how does it work within our School of Medicine? The Gordon Center is what's defined at the University of Miami as a center of excellence. And center of excellences are defined as transdisciplinary, multi-professional units who are not under the governance of a traditional basic science or clinical science department because of the nature of the work it does. And so I report directly to the senior academic officer or dean of the School of Medicine, even though I have a clinical appointment within the Department of Internal Medicine. As their center of excellence, we report directly to the dean. And it gives us a certain amount of freedom to work outside I wouldn't say confines, but the traditions of the clinical department, because we have faculty who have appointments across many departments. And that's one of the features of the simulation community, is that it brings in talent across professions, across disciplines, to carry out the mission that we do. And so at the Gordon Center, we have 30 full-time personnel. These are ranged from 5 full-time faculty, senior administrators, simulation engineers, computer programmers, administration. In addition to the 30 full-time personnel, we have about 40 to 45 part-time instructors. Many of these are first responders who are firefighter paramedics, who on their off shifts from doing their 24-hour duty on call, they come in and train in a variety of our simulation courses. And then we have another 10 part-time nurse educators, although that population is growing. So we have quite a large, diverse unit. We were just talking about the other day, I think, although most organizations have not yet spoken about it or considered it, probably our greatest diversity now is just the multiple generations of staff and faculty who now work at the Gordon Center. We have 5 generations of faculty and staff at the Gordon Center. And while that provides a richness of their experiences, it also raises challenges, particularly when we're looking to adopt new technologies and consider how those technologies will be accepted or not accepted by an individual based on when they were born.
Yeah, I can imagine. And we see that, of course, in our house here too. There's something really, really good about it. But of course, for those of us who are getting slightly more gray in the hair, it also poses a challenge.
It does. We train about 20,000 learners a year. About 15,000 of those are first responders, so those who answer the 911 calls for millions of Floridians around the state of Florida in a variety of different types of courses. We also train all of the medical students, a large number of nursing students, the house officers or residents who staff our large teaching hospitals, and then the large population of clinical providers, the nurses and physicians who are providing care in our health system, who come to the Gordon Center for continuing education.
But if we group that in sort of according to some themes, what are you mentioned, of course, EMTs, but what are the major themes you are engaged with?
I think in terms of the different divisions, we have in terms of the subject areas or the specialties of areas of focus, our largest division is in pre-hospital and emergency healthcare. So those areas that fall within providing care in the pre-hospital setting or emergency healthcare setting, any topic that falls within that area. We also house the standardized patient program for the University of Miami. So a big part of what we do using that technology is focusing on communication skills across the spectrum. Mm. And then a couple of the areas that make the Gordon Center unique is that we have a very large area of educational technology development. We still continue to develop and design newer generations of the Harvey simulator. We do a large amount of curriculum development. And then we take those packages of curricula and disseminate it across hundreds of institutions around the state of Florida and a few thousand around the United States and the rest of the world. Tied to that curriculum development is strong and robust instructor development, because we've learned over the years, when you use simulation, you need a strong curriculum, but you also need instructors and support staff to be able to deliver that.
Yeah, that faculty development piece is coming up again and again, isn't it?
Yeah.
If we shifted gears for a little moment, I wanted to let you know that one of the first publications I actually read in this domain when I came to the area was a publication where you were the first author. It was a publication that was called Features and Uses of High-Fidelity Medical Simulations That Lead to Effective Learning, BME, Best Evidence Medical Education Systematic Review. This was actually published back in 2005, but in many ways, and I just reread it the other day, I think it's just as relevant today. Like I said, you were the first author there with some good colleagues. In this review, it seemed to me you tried to pinpoint under which conditions medical simulation yields the best or most learning. And you went on to present a list of 10 such conditions ranked by the reported effect on learning in the studies included. Could you sort of fly us into why this study was important at the time, and perhaps also what you think of its relevance today?
Right. Thank you so much for that opportunity. I remember the day at the time Professor Ron Hardin and Professor Ian Hart were visiting the Gordon Center at the University of Miami back in 2000, and they had just come up with this idea of Best Evidence Medical Education Reviews, or BEME, where the idea was to look at the literature and identify the best evidence for a particular educational practice. It wasn't just evidence-based, it was best evidence-based, because they realized that in some areas of education research, the evidence may not be as strong that would meet the level of clinical science or basic science. But that didn't mean that after a 10-year period or a 20-year period, there couldn't be some key elements that you could distill from that and inform the field as it went forward. And they had the vision of seeing where simulation was around 2000 as we were entering the new century and where it was going. And so they came to us at the Gordon Center. They know we had experience for more than 2 decades using a variety of different simulation modalities and carrying out some research showing its effectiveness. And so they put the charge of us of this new type of BEME, or Best Evidence Medical Education Review, to come up with a question that would inform the simulation community in its adoption and, more important, its application of simulation. And so you identified the title about features and uses of high fidelity simulation that leads to effective learning. It took our working group probably 4 days of heated debate and arguments, very collegial, to come up with that statement, because we could have said, does high fidelity simulation lead to effective learning? Well, we already knew it did. We had evidence that it did. And we felt that people are going to be adopting simulation regardless of whether there was evidence or not. But if they were going to do it, we would say, well, in those conditions where there was effective learning, why was there effective learning? What was it about the use of the technology, aside from the technology itself, that led to good outcomes? And so that's why we turned the question a little bit to looking at more of a positive aspects, recognizing that, of course, there are studies out there that showed that simulation didn't work or wasn't effective as traditional learning or traditional approaches. But that wasn't our goal. Our question was intentionally to identify studies in which there were positive outcomes and try to distill those features that likely led to a more effective outcome. And so in doing so, we used our own experience of those elements that we felt in our own studies that led to effective learning, as well as looking at the literature of other reviews that looked at psychomotor skill development or clinical skill development and adult learning principles, and identified a list of them and then said, we're going to review the entire literature, going back to some of the seminal articles in the late 1960s with the SIM-1 anesthesia simulator, not be defined by a clinical discipline or specialty, be broad-based. And I think that speaks to the diversity of our working group of not being one discipline. And let's just do a forensic analysis of those several hundred studies to see if we could come up with some common elements that could inform the simulation community moving forward. And that's pretty much how it started at the very beginning.
And like I said, I reviewed it again here the other day, and I'm still thinking it holds a lot of relevance. I mean, like the two top ones that sort of sticks out on the sort of the top indicators was providing feedback. I guess some level of debriefing is included in that, and repetitive practice. Could you unpack these two a little bit more so people can sort of get on board with what you put into that?
Sure. It seems intuitive now that in developing any skill, that some skills to develop if you're a novice and you want to move into hopefully beginning an expert, or certainly to a level where it's safe to perform that skill on a live patient, that you're going to need some sort of practice. And if you want to improve, there has to be some feedback to let the learner know, or to let a team know that what you're doing right, where you're coming up short, what are some tips to improve your approach. We realized that, yes, feedback was important and repetitive practice was important. But I think the questions we have to answer and still haven't been answered over these 20 years is, but what elements of feedback? What approaches of feedback? Is it feedback delivered while you're practicing? Is it after the exercise? How much feedback is necessary? And it really depends on your learner population. It depends on the type of competency or skill you're trying to impart. An example is often in an exercise where we're teaching communication skills or team-based skills, we'll have learners go through a 10 or 15-minute scenario. Something dramatic may happen where there was a bad outcome. The simulation ends and we take the learners into a different environment, often a different room nearby, in a safe environment, and do a formal debrief, which may take as long as the exercise itself if you want people to participate and to come away with some elements that they can build upon. That's in one situation. Another situation might be with our first responders, where we're having them do chest compressions or inserting an IV. In that situation, they just need direct feedback if they didn't do something wrong. We don't need to leave the skill station. We don't have to have them go into a safe environment. It's really just stopping what they're doing, maybe positioning their hand, changing the force of their compression or maybe the timing, and then gives them an opportunity to practice some more. In addition, students are still early on in their training. They have a long way to go before they're actually caring for patients. Whereas a first responder, the very next day, they might be answering an emergency call. And so they don't have the time to sit back and reflect. Sometimes the skill just takes some direct feedback to guide them, and they get it. They understand how they're going to use this the next day. And so that's an example of why we identified feedback. Our recommendations in that other studies that they're in that original review was that we need more studies to tease out the nuances of feedback and the type of feedback, rather than saying every simulation requires a separate debrief room and 15 to 20 minutes of debriefing. So we can do a better job at that. And then with the repetitive practice, it amazed us, even going back to 20 years ago, of how many studies were designed where they wanted to impart a pretty complex psychomotor skill, but only gave very novice learners one or two opportunities to practice. Why? Because those sessions were defined by time. They weren't defined by achieving a competency level. And so if we want learners to achieve a high benchmark, the time should not be defined. The competency level should be defined. And then each learner should use whatever her or his need in terms of time to achieve that competency level. And so when you look at that, you see that learners, when they're learning skills for the first time or refreshing their skills, often need more time for repetitive practice tied together with feedback in order to achieve a high level.
You're listening to 1 Million Lives, a Laerdal podcast.
funny enough, and I don't know if you're aware of John Hattie's work. I mean, his study that sort of came out between two binders in the book called Visible Learning, he came up with the same two factors on top.
Right.
And this is for general education. So I think you were on safe ground recommending this. So that was really interesting. So this study was published back in 2005. And I'd like to fast forward actually to this year, to 2023. We were both present at the research summit of the International Meeting of Simulation in Healthcare. And I have to admit, I had expected the situation to be much advanced based on your insights and knowledge, and perhaps even getting us to a point of guidelines or recommendation. But somehow that didn't really come through. And I remember the two of us, we had a brief sort of exchange there, and I probably expressed a bit of disappointment that the strength of the evidence for these key principles, like you mentioned, mastery learning, debriefing, feedback, spaced learning, didn't quite seem to be there yet, or at least to a very variable degree. What is your view on this?
Well, thank you for that opportunity, and thank you for your honesty in how you felt, because I share that opinion and belief, and I still do. And I was part of one of those groups, so I'm guilty of being part of this process of doing a very thorough review. And our particular group was looking at mastery learning and deliberate practice, reviewing well over 50,000 abstracts, and then coming away with not much more guidance than what we knew 20 years ago. And I think there were a few reasons for our own topic review group, and I think some of the others, is that we still, in terms of looking at those studies where we're going to include in the review our inclusion criteria, I think we're still too rigid at trying to apply those same criteria as a clinical medicine study or basic science study to education practice. While we certainly want some level of standards and some rigor in the criteria, education is a much more messy in terms of a very pristine and sterile environment of basic science or even clinical science. And while some people say, well, that's a limitation of education and training, I think that's just the reality and part of the richness, that we don't want studies that are so tightly controlled in very rigorous settings that they can't be applied to another institution or certainly scaled. And I think we were guilty in this review of reapplying those rigorous standards. And so while those that we identified were strong studies, they were very small in number. If we took a step back and opened up our inclusion criteria, there were many more studies that showed positive outcomes, for which I think we could identify either new features or certainly more nuanced features of those characteristics we already know that were effective. For instance, the feedback or the type of practice, whether it's continuous practice or spaced repetition. Those studies are out there. I think part of the flaw was us thinking that the science of simulation research had reached the level of the clinical sciences, and we so much want it to be at that level that we're not really recognizing that it's a field into itself, and that maybe we have to come up with new criteria on how we select those studies for review. I think after the first pass, our group certainly recognizes, the one looking at mastery learning, proficiency-based learning, deliberate practice, that along the way, we have tagged studies that we're going to re-review, do a deeper dive to tease out those elements that we think that we are pretty sure are important. One of those, for instance, that often is not discussed is the role of the instructor, or role of the facilitator. When they have an active role in the learning process or in the training process, often that's not captured either well, or just not identified as being an important element, but we know that's true. The other important element is whether simulation or the use of simulation is a requirement or has become institutionalized at that institution, it may be the clinical skills center, the residency training program. Because if it is, and if it's identified as such, we know that the institution is putting in the resources to ensure its success, as opposed to being a one-off study by a champion who has just entered the field of simulation. It may be do very well for a 1 or 2 year period. But if that champion faculty member moves to a different institution or becomes successful and is promoted and now has additional responsibilities, often that successful program will not continue that success unless it becomes an institutional directive of the organization.
And it's very interesting you saying this. In a previous episode where I had the pleasure of talking to Dr. Paul Frampus, he sort of used something similar when he spoke about the clinical field, the hospital field, where he used the term deep integration. Mm-hmm. And it sounds to me like there's sort of a handover or crossover almost to what you're saying here, and that's very, very interesting.
I think that he makes Dr. Frampus makes an excellent point, and it was one of the area that we may come to in this discussion, but a point I wanted to make. I think another area where the simulation community or those engaged in simulation research and scholarship have come up short is that there hasn't been enough translation of the training that occurs in simulation centers or clinical skills centers in seeing their application in the clinical environment, if that's the goal. We know that there are issues related to patient safety and medical errors. And while there's certainly no doubt that simulation has been adopted wide scale and its use has grown, the field has grown in terms of the sophistication of the people delivering the simulation, certainly in the investment in simulation and all of the resources that are needed to deliver simulation, we really haven't moved the needle or made an impact on reducing errors system-wide and making an impact on patient safety. And I think it's because the simulation community hasn't done a good enough job or made a strong effort of working with their colleagues in the healthcare settings, of ensuring that what they're doing in a tightly controlled laboratory is going to make an impact in the clinical environment. And that's one of my areas of focus, both on a personal level and institutional level at my institution at University of Miami. And something I hope that the Society for Simulation Healthcare and its other affiliate organizations can have a more intentional mission over the next 10 years.
Yeah, and you are uniquely positioned. I mean, this is a brilliant segue into the fact that you're currently the president-elect of the society, and so you will take over the wheel come January.
January, that's right.
Yeah. So you must have given some thought about your opportunity there at that wheel. I understand it's a big machine, but still to influence based on what you just said. Any thoughts to share on that?
Sure. I think I was fortunate to come in just at a time when the leadership of the society, the board of directors, the past president and current president are in the middle of a 5-year strategic visioning plan that will be formalized this November and then implemented in January 2024. Of 5 key areas that the society will focus over the next 5 years. Number 1 is advocacy. Advocacy not just on the use of simulation to those in key positions, whether they're government, non-for-profit, global organizations who are dedicated to improving healthcare, large healthcare systems, or large universities who haven't yet adopted it. Goal is not just to advocate for the use of simulation as a new technology, but to advocate the impact that simulation can make to some other cause, whether it is reducing errors, whether it is improving patient outcomes, whether it is improving efficiency in the delivery of healthcare, whether it is to provide a tool for large-scale workforce training to meet the needs of that there aren't enough healthcare providers to meet the growing older population globally. And I think those people who are in control of making those large decisions that can make an impact on public health don't have to be sold on technology as an effective tool. They get it. They want to know how it can be used to solve their problems, which are reducing the burden of disease, improving overall healthcare, reducing costs. I think for too long, our society, as it's grown, has been in a defensive posture of justifying the use of technology as a new tool alongside a lecture or alongside small group learning. And I think we've grown enough, we have to get beyond that in reaching out to potential allies that we can realize the potential of simulation, but only when we understand the goal is not simulation. The goal is how we can use simulation to achieve a much larger impact and outcome at a society level. And so I hope that in my position as president-elect and as president, that our society and the broader simulation community can have those discussions with these large organizations so we can change the discussion to more on outcomes and impact and less on the process.
I learned from our chairman here that it was not that long ago since you were actually integral in a recent Lancet Commission meeting talking about healthcare education towards 2050, which is a long perspective, but also a very important perspective given what you just talked about. And I'm wondering, how do you see the outcomes from that meeting interleaving with what you just said about what needs to happen in the simulation space?
No, thank you for raising that up. I'm very fortunate at being at the University of Miami when our current president of our university, Dr. Julio Frank, who is a physician, was as part of his leadership of being the dean of global health and public health at Harvard in his previous position, but also in several positions he's had with the World Health Organization of looking at a broader view of the role of education and training in preparing future healthcare providers to meet global needs. And so the meeting in last November was a 10-year update of the original Lancet Commission paper in 2010 to see what's happened over the last decade. It's certainly informed by the pandemic and how that disrupted not just our lives in general, but certainly in education and training. And there's several themes of that conference that's leading to a couple more papers that I think interleave well within what we are trying to achieve within the simulation community. One is a focus on competency-based education. We talked about this earlier, where the goal is achieving a certain level of competence and designing our education and training to ensure all learners, all practitioners are meeting a minimum threshold. And that minimum threshold is not so minimum. We should set high standards and provide the resources and tools so that we know when someone has done or completed training, whether they're a nurse practitioner, an EMT, a physician, the institution, but more importantly, society can be confident that they have the skills to deliver healthcare. And also, if we come up with some universal standards in terms of competency, as our world shrinks and as people move from country to country, we can have a common standard on what it means to be a practitioner of a certain profession and allow a more of a migration of practitioners where there's a need in a particular country or a particular region to provide care. Related to that is interprofessional education. It's recognized that we often work together in teams, but we train in silos. And more, the complex healthcare problems of society, certainly those in the future, require teams comprised of people of multiple professions across many disciplines. Traditionally, we just focused on those within healthcare, but more and more, we need the talent and expertise of people outside of healthcare who have now entered the healthcare industry. These are sociologists, ethicists, people within business and communications, technology. And it's recognized that having a diverse team of talent together with healthcare providers will lead to more effective solutions, again, to these very large problems that we're facing moving forward. And then the enabler for competency-based education and professional education is technology-enhanced education. The pandemic showed that leveraging technology doesn't mean that everything has to shut down. If you set high standards in terms of the expectations that we want people to have in terms of competencies, making sure that we're going to make it scalable and accessible and equitable, the technology usually finds a way. The creative people, usually the rate limiting step in delivering effective training is not on the technology side. It's usually on the human side. And so we came up with some principles where we saw that technology, its appropriate use of technology, can make an impact not only on the future of healthcare, but also on the future of education and training for healthcare.
Can technology also be an equalizer here in terms of resources, low-income countries, high-income countries? Right. It seems to me that there's a big difference when it comes to opportunity of leveraging that technology. But it doesn't have to be what we think is high-tech, I guess. Didn't you discuss that in the meeting too?
We did. We discussed that often the solutions for education and training come what we call the global north, or countries in the northern hemisphere. And the best practices or evidence of using a technology are defined in the global north and then somehow exported into the global south, where they may be effective, but often not, because the resources required, one, to acquire the technology itself, which may be very expensive, or the talent and expertise to operate it may not be present in the global south yet. And so often those new approaches using technology are tried out and they don't work because they weren't developed with understanding the local needs or the regional needs in developing countries. And so a key theme is that if we're going to come up with solutions for the future problems, particularly in 2050, when as Tor Laerdal in the final session of that conference made the point that 50% of the growth of the human population between now and 2050 will occur in the continent of Africa, then I think we need to do more work with finding solutions that begin in those countries, in Africa and other countries in the global south, and come up with solutions that work there. And then perhaps take the lessons of using low-tech technology or other creative uses of technology in those regions. And maybe we can learn from them of how we can do things a little bit more effectively and a little bit more efficiently in the global north. And so I think there's going to be real intentional efforts by both institutions and large organizations and companies of looking for local solutions in those developing areas that do not have, as of now, the infrastructure or the talent or expertise to use very high-tech or expensive technologies. And I think overall will not only solve the solutions in those developing countries, but it will inform a better use of how we may use technology in the more developed countries.
I'm getting more and more optimistic as you speak. We also see this back and forth, this ebb and flow now, because between what you call the global north and global south, because like there are projects like the Safer Births Bundle of Care who show tremendous outcomes, probably outcomes that we could only dream of in some parts of the global north. So I think we're probably going to see more and more of this back and forth. I hope we do. And like always, Barry, this conversation has been a true treat. I learned a lot, and I'm sure our listeners have been given a lot to think about. Thank you so much for taking your time and sharing your insights.
Well, thank you, Michael. It's been an absolute pleasure. And just on behalf of the listeners and the other people with whom you speak, just thank you and the Laerdal company for putting together this podcast. It's so important to be able to have this forum, to be able to share ideas and learn from each other. Thank you.
All right, dear listeners, there you have it. From one of the greats in the area of medical education and healthcare simulation, Dr. Barry Isenberg. As always, we welcome your feedback and suggestions, and if you want to make sure not to miss out on any new episodes, just hit the subscribe button in your browser. You can reach us with any feedback you wanted to give us at podcast@laerdal.com. That is podcast@laerdal.com. I will also make sure to leave a link to the Gordon Center's webpage together with this episode. All the best and take care. Bye.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.